Welcome to iTubeOD. I'm Dr. Gina Wesley, and I'm here with Dr. Eric Schmidt. Thank you so much for joining us today.
My pleasure. Thank you.
Yes, and we're going to be talking about your presentation you delivered, Updates in Glaucoma. Please tell me, what are some of the primary updates that we have right now in our profession?
Well, the hot topic in the glaucoma world is how to really determine how much the IOP is fluctuating over a 24-hour period. We know that the IOP is highest in most people out of office hours, and so the challenge becomes, are there any markers or indices that we can find during office hours to help determine whether or not the pressure spiking, and to lead us to perhaps treat the pressure better and more aggressively in those cases.
Sure. It sounds like, we need to have a better, markers for our data and evaluation. There's also some new medications on the forefront too, is that right?
Yes, ma'am. There's two new medications that'll be rolling out. One this month, Zioptan. It's a prostaglandin called trafluprost. It's by Merck. The big thing on that is that it's a preservative-free prostaglandin. There's been two studies on it that have shown that, well, first of all, it's preservative-free. It's unit dose in a vial. So you use it once a day. It's indicated for once-a-day dosage, just like the rest of the prostaglandins are. The big thing there is its efficacy, and the clinical data shows that you get about a 6 to 8 millimeter drop in pressure from a baseline of 24 to 26. So it's showing, at least early on, that it's a 25 to 30% drop in IOP, with the hopefully the ability to not incite so much ocular surface disease that we see in chronic disease.
Absolutely. Certainly dry eye, other issues are issues with our glaucoma patients when treating them. The normotensive glaucoma patient is very confounding and scary for us to deal with. Tell me a little bit about what's on the horizon for normotensive.
Well, that's a good question. There's a lot of indication that sleep apnea is an indicator for normotension glaucoma, and not just the mere presence of sleep apnea, but the severity of it. So basically, in a nutshell, clinically, if your patient is on a CPAP machine, for instance, for sleep apnea, if there's apnea is that severe that they need treatment for sleeping, the studies show that it's about a 7% likelihood that patient is going to develop normotension glaucoma. So despite a pressure of 12, that's the other interesting thing in the studies show that the pressure is normal in most of these patients. Pressure is not, IOP is not a risk factor in those cases. The IOP in most cases are going to be normal, but the simple fact that they have sleep apnea severe enough to use a CPAP machine induces perfusion issues while the patient's sleeping at the optic nerve. And so the clinical moral of that story is, your patient's on a CPAP. First of all, I think we should ask about the presence of sleep apnea in these patients. And if the answer is yes, I do suffer from sleep apnea. Is it moderate to severe? Once you get to the moderate level, you're about 5.5%. The risk factor is about 5.5%. If you're severe, again, CPAP type machine, it's over 7% incidence that those patients are going to develop normotension glaucoma. And so the bottom line, in my opinion, is if they do use a CPAP machine, you should visual field them, image them, fundus photo, treat them as a glaucoma suspect.
All excellent information. And on the lines of progression and tracking our progression, what is at the forefront of our instrumentation to help us do this?
Well, I think the OCT has long been the diagnostic machine for retina, but there's been some limitations for the glaucoma aspect of the OCTs. It's just the information that it images has been limited to kind of optic nerve and below. And although it was good data and we could use the information surrounding the topography of the optic nerve, recently what's come out in 3 of the 4 instruments now is the ganglion cell complex, the ability to image the GCC as they call it. And they'll take actually the swath of retina that makes up the nerve fiber layer and the dendrites that go above and below that, and we'll mark that as a progression indicator against their standard their normal database. They'll do standard deviations to say whether it's outside normal limits, whether it's inside normal limits, and whether or not we're actually showing progression based on density and again ability to counteract that with a normative database. And so people would say, well, you know, what's the big deal in that? I thought it was an optic nerve disease. If you look closely at the density of the ganglion cells, it's densest in the macula. And I'm under the opinion that glaucoma starts in the macula and kind of filters on back towards the optic nerve head, where we're traditionally looking for rim thinning. So if we can image it over there at the macula, we can pick up thinning of the ganglion cell layer earlier, and it just allows us to be aware of the possibility of that disease earlier, to do visual field earlier, to watch, to do these OCTs more regularly, and to just heighten our awareness for the presence of the disease. I mean, I truly think that if you're showing thinning on the GCC against the normative database, they have glaucoma despite their pressure.
I think that's all really helpful information for helping the practitioners out there treating glaucoma to understand the changing paradigm. So thank you very much for joining us today, and we appreciate you being with us.
Oh, my pleasure. Thanks for having me.